Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
Thank you to all of our listeners for joining in for another episode of Redefining Medicine, our weekly podcast. I'm excited to welcome Dr. Robert Superko, a clinical investigator and professor based in Carmel, California. Thank you for being with us, Dr. Superko.
It's a pleasure to be here, Lindsay. Thank you.
You have an extensive body of knowledge and experiences across a number of different clinical areas and roles, including serving as director of the Stanford University Lipid Research Clinic and Laboratory, the director of the Cholesterol Research Center at the University of California-Berkeley, the director of the American Heart Association Lipid Disorders Training Center, and the founder of Berkeley HeartLab, just to name a few. Looking back, what experiences most stand out for you or had the greatest impact on you as a healthcare provider, and why?
Well, that's a very interesting question, Lindsay. And at this point in my life, where you've worked for 50 years or so in this field, it's informative to think back on what caused you to get into it. And as you asked that question, two things came to my mind immediately. The one was my father. My father was a United States Navy captain, served his country for many, many years. And then when I was in medical school, he suddenly dropped dead of a heart attack. So that kind of wakes you up and you wonder, why did this man who was in relatively good health just suddenly drop dead? And at that time, we didn't know very much. So that's the first formative issue, was it hit home, and it was a family issue, which we'll probably talk about a little bit later. The second thing I distinctly remember was when I was training at the university, and you rotate through the intensive care unit, we would spend a lot of time taking care of people with heart attacks, trying to spiff them up to get them over the hump, and then see them out the door. And I said, well, gee, this is really exciting. I enjoy cardiology. We've kept some people alive. But oddly enough, these same people keep coming back about 6 months later. And I said, shouldn't there be some way to prevent them from coming back? We're spending a lot of resources on keeping them alive. We're not spending very much on keeping them out of the hospital. So that was the second very informative experience that said, we need to do more than just treat the acute event. We need to prevent future events. So those are two examples.
What experiences are you most looking forward to as a healthcare provider when you look ahead?
Well, I think one of the most exciting things is genetics. And one of the last jobs I had was as chief medical officer of a company called Celera, which is a company that decoded the human genome in 2001. And at that time, to decode one person's genome cost $100 million. $100 million. So give me that amount of money, and I'll tell you everything we know about your genetics. That can now be done for like $600. So what's really exciting is because of the transformation of cost, the change in technology, the use of genetics is a viable thing today. It used to be something that would cost way too much money. But now we know that it can be applied to routine decisions like what kind of diet people should be on, what kind of drugs have a good or a bad response to them. And something we're going to talk about at the omega-3 session soon is whether or not genetics impact your response to fish oils. So some people take a 1 gram of fish oil and their blood levels shoot up. Other people take the same 1 gram and they hardly move at all. And part of that reason is genetics. So that's really exciting for me.
In December, you will be leading a presentation during Module 16, the Master Review of Cardiovascular Medicine, breakthroughs titled The Clinical Use of Omega-3 Fatty Acids in Cardiovascular Disease. Can you provide us with a little preview of what you'll be sharing with the attendees?
Sure. I'm going to go through a series of things in the course that will end up talking about specific recommendations and clinical treatment modalities. But the first thing I'll address is there a need for fish oil supplementation at all? And the answer to that is that yes, because it meets an unmet clinical need. And the unmet clinical need is that we're really not doing a very good job in terms of preventing coronary events. So I'll go through this concept of relative risk reduction and absolute risk reduction, which sounds a little arcane, but is really, really important. So if you take the cholesterol-lowering field, for example, you often hear about a 25% relative risk reduction in heart attacks if you take a statin drug, for example. But if you look at the data carefully, the absolute risk reduction is about 3.5%. Now, what does that mean? Relative risk reduction is how fewer events occurred in the treatment group relative to the placebo group. Absolute risk reduction has to do with what's the absolute difference. So if you have 4 people and one of them has a heart attack, that's a 25% relative risk reduction because it's 4 and 1. 1 minus 4 is 3, where the absolute risk reduction is the real change in values. And so while cholesterol lowering and that approach to preventative cardiology has been somewhat successful, there's a huge population on drugs still having clinical events. So here's a shocker for you. More people on a statin drug have a clinical heart attack than those prevented from having a clinical heart attack. That does not mean that lowering cholesterol is not a good idea. What it means is that something else is causing heart disease. So what we'll explore in my session is what's the role of the omega-3 fish oil fatty acids and where's the clinical evidence that they should be used in certain populations of people. I find that really fascinating.
Absolutely. For fish oil supplements in particular, is it one dose for all or titrate to a specific blood level?
So the question of how much fish oil to use is a really valid one. And the way a number of clinical trials have been done is we're going to pick one dose. Let's say it's 2 grams or 4 grams of fish oil a day, and everybody gets the same dose. And then we're going to see who has a heart attack and who doesn't. And those studies, by and large, have shown that, yes, fish oils tend to reduce cardiovascular events to a varying degree in different populations. But what's happened recently, and at a 3-hour session we had at the American Heart Association in November a couple of years ago, is what role do blood levels play? And blood levels are much more predictive of who gets benefit and who doesn't than is the absolute dose. Because some people get 1 gram a day and their omega-3 blood levels can shoot up dramatically, particularly EPA, and others have very little effect. And one of the reasons for that are these genetic differences in what's called the FAD alleles. So to answer your question, it looks like it's more relevant to get to a certain blood level than it is to take 1 standard dose per day. It's sort of like the old cholesterol field, where is your goal get everybody on a cholesterol drug, or is your goal to get the LDL cholesterol down to 130, 100, or 70? So we're in that same territory now with the fish oil discussions.
Let's discuss blood cholesterol reduction. Is a 25% relative risk reduction enough? Does an LDL-C of 30 milligrams per deciliter cure CHD?
So here's something interesting about the cholesterol field. Most people with a coronary event, and this is a huge study of 200,000 people, coming into the emergency room with a heart attack have absolutely normal LDL cholesterol. 75% of them have an LDL cholesterol under 130, and about 25% have an LDL cholesterol under 70, and they're still having a heart attack. So while identification of high cholesterol is very important to detect and treat, most people with heart attacks do not have classic high LDL cholesterol. Thus, something else is causing the disease, one of which is the fish oil story. So a 25% relative risk reduction is sort of nice, but it leaves a whole lot of people untreated appropriately that are still going to go on to have coronary events.
Will you discuss the importance of family heart disease clinics?
So, Lindsay, one of the things that my wife Brenda and I are most proud of is the concept of family heart disease clinics that we started back when we were in Atlanta. And if you take a medical board exam and they ask the question, what's the most important risk factor for having a heart attack? The correct answer is not cholesterol or blood pressure, it's family history. So if you have a family history of heart disease, your risk of having a heart attack is significantly higher than other people. And why is that? Well, that's because of genetics. So we started a clinic in Atlanta where we would go through the hospital. This was in the early days of the use of genetics. We'd go through the intensive care unit and the post-coronary or heart surgery bypass unit. And we'd say to the patients, we have a program where we can identify why you have heart disease and why you needed these procedures. And a lot of it is genetics. So we could measure those things in you and then call in all your first degree relatives, your brothers, your sisters, your adult children. And we can say, we found out why your dad has this problem. Now let's look at all the family members. And for Mendelian dominant traits like elevated Lp(a), for example, 50% of the first degree relatives will have the same problem. And then we say, okay, we're going to focus our energies on that 50%, whether or not it be treatment or non-invasive imaging or other modalities. The other 50% are in a totally different genetic category. So this concept makes a lot of sense. We've written a number of papers on it. We've run clinics on it. The problem is nobody makes money. So it takes a lot of energy to contact the family members, to bring them in, to explain what's going on. And there are no billing codes for this. So large medical institutions have not adopted this model, even though it makes eminent sense. But through our nonprofit organization, we've been doing this around the country for probably 20 years now. So family heart disease clinics is a very important concept for people to appreciate because it can detect the really high-risk people in your family. And that's obviously important to you, right?
Definitely. You have a particular interest in preventative cardiology for firefighters and law enforcement, having completed a firefighter heart disease prevention study in 2007. Will you share with us your findings regarding this particular population of patients?
Yes, the firefighter story is really fascinating. And it starts back in 9/11, the 9/11, when Brenda and I were in New York City and were there when the plane struck the tower and we were at a meeting and talking to people. So what we noticed as we were trying to escape is there was one group of people that were running towards the tragedy, not away from it, and they were firefighters. So this immediately caught our attention. And then we went back to Atlanta eventually. And a few months later on the news, the fire chief came on the news and said, I'm sick and tired of going to funerals for my firefighters. They're not dying in fires, they're dying from heart disease. Can anybody help? And we were in the preventative cardiology realm. So we thought about it, did research, read a lot of things, and it turns out that firefighters have about 300% more heart disease than other professions. And this is well established through a lot of federal research studies. So we said, well, we know they have more heart disease, but why? So I wrote a grant, a big FEMA grant, and we got your tax dollars to do this big study in Atlanta, published it, and basically we found out why the firefighters have such a high incidence of cardiovascular disease. And we can go into that in some detail later if you want. But then we said it's our moral imperative to screen firefighters around the country. So through a nonprofit, we go to different cities in the country and set up screening programs to identify firefighters that are extraordinarily high risk. And it turns out that 1/3 of active duty firefighters, strong, strapping people, actually have undiagnosed coronary disease. They have coronary disease that's not so bad that it's going to make them drop dead next year, but they have the beginnings of it and evidence for it. And 2/3 don't. So those 2/3 are fine. The 1/3 we focus our energies on again. And it turns out some of the things that are related to this have to do with the metabolic syndrome issues and thrombosis. Because when these guys go into a fire, you get volume, your blood volume gets contracted, you get hemoconcentrated, you have intense heat, and our hypothesis now is a thrombus easily forms, causes the coronary event. So most firefighters, when they have a heart attack, have it around the time of fighting a fire. So this is something we're really proud of and would be happy to share with anybody.
How has COVID-19 impacted your work as a clinical researcher, as well as in the field of clinical research as a whole?
So the COVID-19 infection has had a dramatic impact on research, primarily how to complete clinical trials where you need people to come in and be questioned and take their blood pressure and draw their blood. So many people rightfully are reluctant to do that at this point. So a lot of the large clinical trials have been slowed down, if not halted, until we get this under control. It's helped actually because then there's a whole new area to investigate. And there's a lot of research going on. We're doing some, it's going on all over the world. So oddly enough, the upside to this is that it provides a whole new area of research, and one of which is the long-term cardiovascular effects of COVID-19. So we certainly don't want people to catch it, number one. Number two, if they do catch it, we want to make sure they stay alive. And the area that's now been developed is if you've had COVID, what's your chance of having heart damage 3 months, 6 months, 12 months down the road? And that appears to be a really significant thing that's growing in awareness. So having the COVID virus is not just, can you survive and get out of the hospital alive? It's, are you going to have heart failure 3 to 6 months down the road because of COVID? And if you are, how should we detect that? Who should we treat? And how aggressive should we be? So that's a very ripe and new area of research because of the COVID-19 infection.
Well, thank you so much, Dr. Superko, for spending time with us and sharing your insight. We do look forward to your lectures coming up in December. We'd like to also thank all of our listeners, and we will catch you next time on Redefining Medicine. Again, thank you so much, Dr. Superko, and have a wonderful day.
Oh, thank you, Lindsay.
Thank
Bye-bye.
you. Bye.